Howdy, everybody, and welcome to our podcast, Eggs, Ethics, and Everything in Between. I'm Charlotte Osburn, a senior at Northern Arizona University, and today I will be interviewing Dr. Jeffrey Osburn, our expert in reproductive health care. He is an OBGYN located in Prescott, Arizona. Dr. Osburn, please introduce yourself.
My name is Dr. Jeffrey Osburn. I am an OBGYN. I've been in practice since 1994, always in the field of OBGYN. For approximately 4 years, I was faculty at University of Oklahoma in Oklahoma City. I ran the medical student rotation and was involved in medical education, both from med students as well as residents in the field of OBGYN. Since May of 2002, I have been in private practice in Prescott, Arizona, performing surgery, delivering babies, caring for women since that time.
All right, thank you. So I'm going to start us off by asking, what is your understanding of bioethics? What is anything you've been taught? What is your understanding of it?
Well, with regard to bioethics, it's the ethical treatment with respect to what I do, the biology and reproduction issues that come about as an OBGYN and the ethics involved with that. That can be anything from pregnancy related issues all the way through to patients deciding on pregnancy related things or their reproductive rights.
So Google defines bioethics in a general term as an interdisciplinary field that examines the ethical, legal, and social implications of advancements in the life sciences and medicine, focusing on issues like genetic engineering, artificial intelligence in healthcare, and the allocation of medical resources. As of late, the most common issues that seem to be coming up have been in genetic engineering, as well as the upcoming artificial intelligence and how that impacts our healthcare, and the struggle of what resources go to who and how we determine that. A big part of bioethics are its 4 characteristics or main branches, which is beneficence, non-maleficence, autonomy, and justice. As for beneficence, that is the ethical principle and practice of doing good and acting in ways that promote the well-being of others. How do you feel that plays into the reproductive health field the most?
Well, as physicians, we have taken the Hippocratic Oath, which by definition says, do no harm. With respect to medicine in general, that's what the intent is to care for patients and do no harm in doing that care. With regard to, OBGYN, the guiding principle is, again, do no harm, but you also want to deliver the best care possible and do the best for the patient that you can. The idea of beneficence is critical. Otherwise, why do it? If you're not there for the best and do your best for patients, you got to question yourself.
Our other branch that I have a question for, justice. So the ethical principle of ensuring fair and equitable treatment for all patients, regardless of their race, ethnicity, socioeconomic status, or other factors. How do you feel justice plays a role in terms of a pregnant woman? Do we follow the justice more of the mom, more of the baby? How does justice really play a role in terms of that area?
Some of the justice issue obviously involves question of abortion. The concept of abortion with respect to justice versus, say, somebody's religious background or ethics is very different. That's where, as an OBGYN, I have not had that be a part of my practice, in part because it's just not ethically where I want to be. In trying to do good for patients and doing no harm, understanding when patients have that desire, then I also don't feel that it's my place to not make sure they get the best care possible in making that decision. My approach is I help patients decide what they want to do, get the best care possible for them with their decision. Obviously, if it's to keep the pregnancy and or keep the pregnancy and adopt, I help them along those basic premises as well. Then you start getting into, the issues with regard to pregnancy and even then viability, especially practicing in a rural setting. I do keep that in mind with respect to making decisions for patients, especially if they're on the cusp of viability, of making sure that that patient is put in the best care situation possible to be able to care for that unborn child should they birth, that they could have everything possible done to help make that a successful delivery and life.
In terms of ethics outside of bioethics, do you feel a lot of people involved in reproductive health care allow their personal ethics to affect their care? And if so, to what extent have you seen?
Oh, I think everybody's approach is different. That's part of why, as patients seek out, healthcare providers, I think that's part of what they should seek out is not only is that a good doctor, but do they approach things in a way that best represents them and or that their wishes, desires will be heard and respected. Some people, again, going back to the abortion issue, don't even incorporate that into their decision or in their counsel to patients, make that a part of their counseling. And so, yes, I think that everybody approaches it differently as far as if they incorporate their Judeo-Christian ethics into their job. I think some people let it affect their decision more than others, certainly. And how that comes out is, especially with regard to caring for patients, sometimes choose to counsel that patient without 100% clarity or 100% clear on all choices, and they guide them into decisions. So that can present itself in a variety of different ways and manners.
A big part of our group's podcast that we're wanting to focus on is asking questions and getting an insight on topics that have been presented that we have seen some women as patients have wanted, but a lot of healthcare providers feel it is not right to do those things. We want to make sure we cover those because we feel that there is certain topics in reproductive healthcare that get covered more than others. So one thing that I wanted to cover that I feel doesn't get very much coverage is the procedure of hysterectomies or even the request of hysterectomies in women that are generally between the ages of 20 to 35 years old. Have you ever had a woman come in requesting that kind of procedure? And in any case that you have, how did you respond, or what do you feel the ethical response to that is?
Yes, I have patients come in and ask for that all the time. Not as much, obviously, in that age bracket as 35 and above, simply with regard to the patients prior to age 21. That's kind of the cutoff. So would I do it in that situation below 21? Only in situations of life and limb, I guess. Over 20, some of it is somewhat dependent on the problem or issue at hand. In what I do, it's more problem driven with regard to a normal tissue and no evidence of any problems, issues, or concerns, just strictly hysterectomy. It's more a matter of talking to the patient and seeing exactly what their end goal is. Obviously, if it's more a matter of just not wanting to get pregnant, there's obviously other procedures short of a definitive surgical procedure like hysterectomy that to help that achieve that sterilization desire. Beyond that, like I said, more the hysterectomy issue is more with regard to being problem driven. Somewhat also this issue is driven by insurance because let's be honest, as physicians, we are not in control of decision making, etc., with regard to especially, a definitive surgical procedure that involves anesthesia, hospitalization, etc. The insurance is going to dictate or decide what they are willing to pay for. I have certainly been in situations as a physician where my medical plan for the patient comes in direct contrast to what the insurance is willing to pay for, and that's where that presents itself in the form of denials or, requiring medical management before surgical procedures are performed. And in some cases, redirecting the surgical procedure to evaluate the patient and the problem short of the hysterectomy. So it's that question is a multifaceted one. The question that I get or that comes to mind most frequently is one of I just had a patient here recently who was 26 years old, had never had a child, and she was requesting sterilization that she knew and had long held that she didn't want children. And in talking with her, she was very grounded, very well thought out, very cogent responses to my questions, and also very mature approach in her understanding of herself, etc. And she matter of factly told me that other physicians had told her that they would not do that because she hadn't had kids. And the concern about tubal regret and the idea with that is that they have a tubal and then later meet someone or find themselves in a situation where they regret having had a tubal. But I felt like at her age and having talked with her that was a procedure that I felt comfortable in doing for her. You do have to look at the whole picture, if you will, not just one aspect of it, but it is also somewhat beyond the physicians deciding as well, like I said, with insurance and other issues.
In terms of things like PCOS and endometriosis, I have heard a lot of stigma behind how hard it is for some people to get diagnoses with these. Why do you think these are such hard things to diagnose, and do you feel there is an easier way that we can help with this?
I think for young women or patients, it's finding a practitioner that is well versed on that topic. For instance, PCOS, polycystic ovarian syndrome, previously used to be known as Stein-Leventhal, and it's because Dr. Stein and Dr. Leventhal put together a criteria set of patients that they were seeing with different metabolic issues, but also problems with regard to their periods and gynecologic complaints. You have to know and understand that the difference between a syndrome and a disease is that the disease has a diagnostic test. In other words, diabetes, thyroid. These are diseases because there is a diagnostic test to make the diagnosis. The difficult thing with this is that there's no strict diagnostic test. It is a criteria set that the patient, based on their signs and symptoms, then may meet enough of the criteria set that then they achieve that diagnosis. So it's a matter of finding a provider that is familiar with the criteria set and an understanding of how that disease entity can present in patients, and then not only making the diagnosis, but then the next step is how do you help the patient correct that? Now, endometriosis is another one of those things where patients, as well as even other non-OBGYN care providers, go off the idea that, well, she has pain, so it must mean endometriosis. And that isn't necessarily a single factor in that diagnosis. The only way to adequately diagnose with direct observation at the time of laparoscopy. Ultrasound may or may not give an indication to the presence of endometriosis. As I said, the pain issue may or may not lead you to an indication of endometriosis. Some of the worst endometriosis patients I've ever had, as far as amount of disease present, they have had no pain. And in part, that's what caused them to go so long before the diagnosis was made, was because they had no pain, they had no symptoms. With regard to the different clinical entities, it's just a matter of finding a provider that is able to help the patient understand, but then also able to achieve a diagnosis and then help them along the way once the diagnosis is made, if that makes sense.
In cases for things like severe PCOS or severe endometriosis, if a patient is to request a procedure that may help them as opposed to something like birth control, but it may decrease fertility rate or cause fertility rate to be zero completely, do you feel it's more of a autonomy versus beneficence matter, or do you feel in terms of severe cases it can go autonomy and beneficence hand in hand to help them?
I think it probably has more to do with finding the right provider. In cases of endometriosis, when the endometriosis is severe, sometimes surgical procedures in which the uterus and or the ovaries are removed is the only cure. Helping the patient understand that, or helping the patient come to that decision when they haven't had children, is an important issue. And in that situation, it is an element of beneficence and helping them have autonomy, because you don't want to force that type of procedure on a patient when they're not ready. The days of I'm the physician, you're the patient, and by God, you will do this, that doesn't exist anymore. I think it also depends on the clinical entity to help that understanding, because in the PCOS entity, patients many times will come in and say, I have PCOS, I can't get pregnant anyway, I just want the uterus out. But the hysterectomy is not curative when it comes to PCOS, because the problem with PCOS is in the ovarian function and how that ovarian function blends with the metabolic hormones. And so hysterectomy in the case of PCOS is not curative. And as a physician, I have spent time trying to help patients understand that, because sometimes the internet and social media can be very confusing, or can be confusing for patients who don't have the medical background, medical knowledge of, say, an OBGYN. My job then is to help the patient have an understanding of what their clinical diagnosis is, and then how to best treat that.
In terms of birth control, there are many options for bioethics in terms of reproductive health care. What is the approach with the suggestion of different kinds of birth control, as well as I have heard a lot of social media stigma around some women feel they are pushed towards one thing versus the other, or pushed to have it in general versus going without it. What do you feel the ethical point is for you as the physician?
I think it's a matter of, again, listening to the patient and understand where they are coming from in seeking out my care. Is that even in patients that I have come in for their annual, I will address are you sexually active? Are you interested in birth control? And if they say no, then respecting that answer and ending the conversation there. It's when you have a patient that says, well, I've tried XYZ and it doesn't seem to work for me, if there is an interest in birth control, then having that discussion with, okay, what would work for you, as far as understanding there are multiple different options, and sometimes making patients aware of those options. Sometimes it's a matter of explaining how methods of birth control work, doing some proper education as far as, well, I've heard, XYZ, and then either validating the patient's understanding or redirecting or correcting the patient's understanding so that they can make a proper decision. Do I force anybody into birth control? No, not as an OBGYN, because quite frankly, especially if it's something that I prescribe, if they don't believe in it, they don't want it, they're not going to fill the prescription or they're not going to pick up the prescription. It behooves me to make sure that I give the patient clear, concise, good information, reliable information, so that then they can make a proper decision for themselves to help themselves and eliminate some of the, I'll call them birth control follies that go on because people try this, that, and the other thing and don't end up being successful. And it's also a matter of helping the patient find what works best for them, even if it's something that I don't prescribe, like condoms or what have you.
And just a general overall, with you having said at the beginning how long you've been in the field, how do you feel bioethics has changed, or in your experience, how have you seen it changed from when you started to today?
Oh my. Well, like I said, back in the day, that there was very much the idea that I am the physician, you're the patient, I know best, you're going to follow what I do or what I say. And that didn't always align with patients' autonomy, and it also did not allow for unbiased counseling that patients should receive, in my opinion. In other words, physicians were, I'm going to tell them that they should do XYZ because I know best, and not allowing patient to participate fully in that decision making, because the premise at the time was, I've been to school, they haven't, I know better. That doesn't exist anymore, or shouldn't, because I feel like you, at this point, as a care provider, reach a point to where you engage with a patient and help them make the best decisions you can as a healthcare, especially as a reproductive healthcare provider, help them make decisions, not dictate decisions to them. I would say that the biggest change or thing that I have seen in the course of my career is that issue.
For future bioethics, having been in this field for so long, how do you feel bioethics should move forward? What do you think the next step should be in terms of creating the best system for patient as well as physician?
Looking into the crystal ball, I think reproductive health wise, you are going to be having to deal with advances in technology and advances in medicine that change, say, with babies, the viability cutoff. And so at what point do you have to think about, okay, I have to do a C-section, emergency C-section on a 20-week baby because we have this technology that then we can put them in a man-made incubator or man-made uterus. I would say the other biggest thing facing medicine, but especially the field of medicine that I'm in, is with regard to the evaluation and treatment of cancers. Knowing what somebody's genetic predisposition is and or the genes involved in, say, a patient's cancer, and then being able to direct their treatment and or evaluation based on their genes and based on the available vaccine protocol that may be able to affect those genes, I think that's going to be the next thing, is the cancer evaluation and treatment with regard to the genetics of cancer. I think it's going to be huge.
And in terms of this evolution of bioethics, what we started as, what we have now become, and what we will hopefully continue to do, do you feel that we are going in the right direction as reproductive health care?
I think with regard to the genetics of things, I think that having that knowledge, understanding, and what we do with that puts us on a slippery slope. I feel that the bioethics of especially not only obviously treatment of disease, but then in the sanctity of life, I think that's a slippery slope. And I think part of that bioethics thing is, at what point do you not proceed with something because you're playing God, and or bridging over into things that have the potential to be used in a non-beneficial way. And I think that's part of the concern in, say, cloning and all those different things, that it's not so much can I, but should we? What is that potential downside to being able to do this or that? It's one thing to be able to create new organs, say liver or skin or cartilage for an ear. Well, then at what point do we have to rein that in because we have the ability to create new organs? Well, then let's just create a person. That's a slippery slope.
In terms of reproductive health care and the bioethics of it, what do you think students now who will be going into the field or hope to go into the field, what do you think is something that they should really focus on or investigate and hone in on to be the best physician that they can be?
Remember why you do it. It's not for ego. It's not for glory. It's not for money. You do it because you want to help your fellow man and you want to make an impact. Sometimes people in medicine end up becoming mechanical and dehumanizing patients and forgetting the humanity. I feel like the more we can talk to people, the more we can understand people, the better off we are as healthcare providers. I remember I had a mentor that said, if you ask the right questions, truly listen to the responses, patient will tell you what the problem is. You just have to be smart enough to ask the right questions and listen to the answers to be able to help do the best for the patient. I've tried to do that.
That's some really great advice that not just for reproductive health care, but healthcare in general is things that everyone should keep in mind.
Oh yeah, 100%.
In any case, do you have any questions for me?
I do not.
All right. Well, I'd like to thank you for coming on this podcast and answering all my questions and hopefully giving someone the motivation or the push that they need to better the world.
That would be my highest goal. So thank you for having me.
Thank you. Howdy everybody, I'm Charlotte Osburn, and today we'll be closing today's episode with No Eggs Attached, our roundtable discussion for eggs, ethics, and everything in between. And in my podcast, I interviewed Dr. Jeffrey Osburn, an expert in reproductive health as an OBGYN. In this podcast, we covered a lot of subjects ranging from past, present, and future bioethics, ethical practices, hysterectomies, PCOS, and endometriosis.
Hello everyone, it's Abby here. First and foremost, a big thank you goes out to our interviewee, Dr. Jeffrey Osburn. Thank you for taking the time to join us on eggs, ethics, and everything in between. Also, special thanks go to Charlotte for kicking off our podcast with such an exceptional interview. It is so important to note that there's a big conversation that exists regarding the ethics behind providing certain medical procedures. Sometimes these are specifically in regards to minors. Other times it's a matter of violating one bioethical principle for another, and how determining its worth is extremely subjective. For example, someone who is unbudging on the principle of non-maleficence may never see the merit of an abortion that could save the life of a mother because it would harm the fetus, whereas someone else may deem it worthwhile. What we learned from Dr. Osburn's interview is that a hysterectomy prior to age 21 is very dependent on medical necessity. It's more about the potential life-threatening implications than age in determining a maturity threshold. There is still an element of decision-making being based on one's understanding of the consequences of a procedure in the context of one's own life. Dr. Osburn's patient, 26 female, is by all legal means able to make these choices. That being said, she was denied multiple times over concerns by physicians that she may have tubal regret. The question that comes up from this is, who should be making that decision at 26? Does that change when you think about a 21-year-old? When talking about criteria sets, how standardized is this practice really? And does that impact care continuity? The answer is, it does. Some providers will provide a service where others won't. Different providers do sometimes let these personal biases impact their care, such as religion. Is there a place for this, or should this be concentrated in the bioethical principles? What about in a community that predominantly follows one religion? Dr. Osburn also mentioned the Hippocratic Oath. The Hippocratic Oath is a standard for many medical oaths. It has experienced many changes and interpretations over time that have changed it. From this interview, one of Dr. Osburn's main principles is do no harm, or non-maleficence. He also emphasizes unbiased counseling and the importance of autonomy, which Jordan will dive into now.
Hello, as Abby said, my name is Jordan. I'm going to be talking about what stood out to me the most, which was the importance of autonomy. So overall, Dr. Jeffrey really emphasized the importance of respecting patients' autonomy. He talked about how a lot of patients come into the office after doing their own research online or seeing things on social media, and sometimes they come in with strong opinions or misconceptions. For example, he mentioned that some people believe a hysterectomy can cure PCOS, which in reality that's not true, since the symptoms can persist even without a uterus. Dr. Jeffrey explained that his role is to provide clear, accurate medical information so patients can truly understand their options, the risks, the benefits, and the long-term impact before making their decision. No matter what their decision is, whether he personally agrees with it or not, he believes it's his responsibility to support the patient. That might mean offering resources, connecting them with the right care, or just walking alongside them through whatever choice they make. He also acknowledged that every physician has personal beliefs and biases, but at the end of the day, his priority is making sure the patient gets the care they need, even if that means referring them to someone else. Like he mentioned, if a patient is seeking an abortion, he personally doesn't perform that procedure, but he'll make sure they're connected with another doctor who can help them. In the end, Dr. Jeffrey's message is pretty clear. It's about compassion, honesty, and making sure every patient feels supported and informed no matter what path they choose.
Hey guys, Charlotte again. In conclusion, Dr. Osburn's points of emphasizing the necessity of actively listening to the patient and recognizing boundaries allows for better care and more receptive patients. It is critical to not push one's own ethics and views onto the patients and to allow for the patient to be heard and feel cared for. Although when he started in the field, it was still the time of doctors being quote-unquote all-knowing, but with the evolution of bioethics, he emphasizes and recognizes that it is and should be all about the patient. Although we covered challenging topics like hysterectomies, PCOS, and endometriosis, Dr. Osburn made sure to point out that not all information we read online is accurate, and that it is the physician's job to clarify anything the patient asks about. He ensures to note that he is here as a resource, not to dictate what occurs, as well as he discusses how a lot of issues in executing proper treatments by the patient's wishes is that the plan insurance has is not always as extensive and effective as the plan the physician has. Overall, Dr. Osburn's message to future physicians in healthcare is to remember why you chose to be in healthcare, to help and heal. As long as these mindsets are kept, bioethics can continue to improve. Thank you again for listening to our podcast. This was Eggs, Ethics, and Everything in Between, where reproductive choices meet ethical questions.